Okay, I'm just going to share my screen. Please let me know if you can see my screen, dear students. Woohoo. Okay, that's perfect. And it is officially 7 o'clock, so we're going to get started. Hi, everybody. Welcome to today's, this is just a bonus MCQ case review session. My name is Dr. Farah. I'm a lecturer with SolRx. I've been working to support international and Canadian graduates for their PBCs for over 10 years. And I'm excited to be here hosting this event. I know MCQ can be overwhelming. It's a challenging exam, especially when you're getting closer to the exam. Everyone's always asking, "Hi." Everyone's like, "How do I prepare? What do I do at the end?" And I think one thing that I've learned over the years is you will never know everything. And we'll talk about this at the end as well. But one thing I really want you guys to know is that you will never know everything. It is impossible to memorize everything. And also, when on your exam you're looking at a question, I find a lot of people say, "Oh, this is the right drug. This is first line treatment," or they'll just automatically think of therapeutics or think of their notes and try to look for the answer. You have to remember that the answer may not necessarily be the one that's obvious to you. You're not looking for the right answer. You're looking for the most appropriate answer. Does that make sense? And when you change your mindset to look at for the most appropriate answer, it will change the game for you. So it's not about the right answer. You're always looking for the most appropriate answer. So, for example, if you're given four different options and they're not the ideal drug that you would pick, you have to be able to work with what you're given. So, that's something to keep in mind. Does that make sense? And, guys, please make sure you participate. If you don't know, say you don't know. If something makes sense, tell me. If it doesn't make sense, participation is the best way for us to work together, you know? But I think going back, that's one thing I wish I knew. And my dear students, please make sure that you guys are muted.
One
Just
hour,
make,
what did it? I don't know what I press. Everything you click.
let me make sure that everybody's muted. Give me one second here. There's some people not muted. Please make sure you're muted. Okay, mute. Thank you. Please make sure you're muted. Bear with me. There's some people not muted. Give me one moment. Okay.
I don't know what I press. Me, I
Okay.
just the tap they go.
Dear students, there's some people that are not muted. Before we can continue, we have to make sure that everybody's muted so that we can have a productive discussion. Okay. Okay. All right. Perfect. All right. Thank you. Okay, so I hope that makes sense. And with that being said, before we get started, do you have any questions? Because I want to start practicing some cases. But before we start, I want to get you in the mindset of don't always look for the right answer. Look for the most appropriate answer. You have to work with what you are given. You have to look at the preferences of the patient. You have to look at the preferences of the case, not your preferences. So that's also something to keep in mind. Another tip I will tell you before we get started is a lot of students will say, "Farah, what are the contraindications to this drug?" In therapeutics, there are rarely any real contraindications, maybe one true contraindication. So, for example, classic example is bupropion. Bupropion is used to treat mental health conditions, but we cannot use it in somebody who has epilepsy. So, bupropion is absolutely contraindicated in somebody who has seizures. We will never use it. But other than that, are there any other true contraindications? Not really. So there are relative contraindications or precautions. So, for example, if somebody has anorexia or bulimia, it doesn't mean we cannot use it. We just have to be very careful and assess the patient. So, what I'm trying to say is, look on your exam when they say contraindication versus precaution. 99% of situations, you can use a medication with precaution doesn't mean contraindication. So these are the words you have to look for. Sometimes I tell students, when you're preparing for this exam, you're preparing for an English exam because you have to look at the words being used. Okay? Acetylcholinesterase inhibitors in dementia patient has seizures controlled with phenytoin. You can, with very close monitoring, you can. Okay? Does that make sense? Does that clarify what I'm saying? Any questions? SIP interactions are precautions. Yes, exactly. They are precautions. What if cases says well control? Can you elaborate what you mean? Like, or elaborate how you mean. Okay. But this is something very important for you to understand. So let's get started and let's do question 1. And I want you to post your answer in the chat, and I want you to also post why and what you think it is. And I'll give about a minute or so for you to answer. So here we go. So on your exam, you have to give yourself about a minute to answer the question at most. Very good. Okay. Very, very good. One of the biggest tips I will give you that has also helped me is when you look at a really big case, you want to look at the first line and the last line, and then you work your way in between. So start with the first and the last line, and then you work your way in the middle. So keep that in mind. And you guys are absolutely correct. The answer is A. The patient has atrial fibrillation. We're looking for a rhythm control agent. The patient has heart failure with reduced ejection fraction, reduced in this case about 35%. So your answer is A. We're not doing rate control. So number 2 and number 4, we don't pick. And digoxin, we rarely pick for the purposes of your exam. Digoxin is an older drug. It is more of a second line agent we may consider in rate control. Very good. Are we good for the next question? Everybody, you guys have to participate or I won't keep going because we're here together. Okay, next question. Here we go. There we go. Next question.
Recording in progress.
Dear students, please make sure you're muted. Now, I've seen something like this come up on the exam. So I really want to make sure this concept we understand. Okay, I'm looking at your comments. And I'll wait a couple more seconds because this has come up in the past, this concept. The answer to this question is number 2. Okay, the answer is number 2. And I'm looking at your comments. Some of you guys are saying 2, some of you guys are saying other things. Okay, so amiodarone can cause both hypo and hyperthyroidism, can cause hypo and hyperthyroidism. So it can cause both. Amiodarone releases iodine. Okay? It can release iodine. Before we start amiodarone, the patient must do blood work. We have to look at their baseline thyroid levels. Does this make sense? And now let's say you have a patient who starts amiodarone. Or if they stop amiodarone, will their thyroid levels maybe go out of whack? So if someone starts amiodarone or stops amiodarone, can their thyroid levels change? And what happens? So I had a patient who started amiodarone, and when they started amiodarone, their thyroid levels went out of whack a little bit. And the best way to manage that is you have to wait several weeks, and then you will find that things will normalize. Okay? Or it'll reach a new normal. So keep in mind that in the beginning, things may look a little abnormal, but so you have to give it some time, and then we retest before making any clinical decisions. Exactly. Now, why, and someone's asking a great question, why isn't 3 the right answer? What's wrong with 3? So remember another thing on your exam, my dear students, more than one option will be right or wrong. Sometimes all the options will be right, and you have to pick the most appropriate one. Students will be like, Farah, all the options are right. How do I pick? So you have to pick the most appropriate. Exactly. So is number 3 wrong or is number 3 right? Okay, let me put it this way. Is number 3 a true statement? Yeah. Number 3 is a true statement. So when we look at number 2, when we look at number 3, they are true statements. But which one exactly? But not the most appropriate. Exactly. See, these little tips, this is how you get through that exam. We say, okay, well, they're all right. Or number 2 and 3 are right, but what's the most correct? Very good. Is that clear? And if it's not clear for anybody, let me know. Clear? Okay, next. Here we go. 3, 2, 1. There we go. Good. And thank you for participating. Okay, I'll wait a couple more seconds. Something like this came up on the exam. When you are preparing in the next week, you make sure you understand amiodarone more than anything. You are right, the answer is 3. But for amiodarone, you have to know what it is. Okay? So amiodarone can cause these micro deposits in the eye. Okay? Now these micro deposits, they call them corneal microdeposits. Are they reversible or no? So if somebody takes amiodarone and they stop amiodarone, will the microdeposits go away or no? Yeah, very important. Now let me ask you something else. Let me ask you this. Very good. It's reversible upon discontinuation. But let's say the patient says, "Oh, Farah, I just went to my doctor, my eye doctor, and my eye doctor found micro deposits in my eye, but I have no symptoms." Do I have to stop the drug or no? If it's asymptomatic. If it is asymptomatic, you do not have to lower the dose and you do not have to discontinue if it is asymptomatic. Okay? Is that clear? If it is asymptomatic, we do not have to lower the dose. We do not have to discontinue. Another thing related to the eye and amiodarone, because this is important. So other than the micro deposits, amiodarone can cause optic neuropathy or optic neuritis. Okay, so this is separate in neuropathy of the eye, optic neuritis, and that can lead to blindness. Is that permanent or no? Yeah, very good. So the way I look at it is I say, okay, you have optic neuritis, and then you have the micro deposits. The micro deposits are reversible. Optic neuritis or optic neuropathy is permanent and it can cause permanent blindness. So I want you to be very aware of that on your exam because amiodarone and vision is very important. Are we clear before I go to the next question? Okay. Next question. You guys will laugh at me. I have 1 cup of coffee and then I have ginger ale. I don't know. I like ginger ale in the evening, so I'm like bouncing between both. So don't mind me. But anyways, okay. Next one. Here you go. So you guys will answer it. Let's do the next one. I'll wait a couple of more minutes.
Yeah, I forgot one of them.
Please make sure you're muted, my dear students. Thank you. Okay. Now, I'm going to point out something really important here. You may be given, depending on the question, in some questions, you'll be given a lot of blood, like lab values. In other questions, you won't be given any lab values. I want to draw your attention to two things. If you look at the lab values, you'll see serum IgE and eosinophils. Those two are elevated. So what does that mean if IgE and eosinophils are elevated? Uh-huh. Allergic. What about C-reactive protein? Here, the C-reactive protein is normal. Okay, so we know there's no inflammation per se, so we're not worried about C-reactive protein. But here, there's allergic involvement. It is always true that we have to look at inhaler technique. So, number one is a true statement. But in this patient, she has a history of asthma, shortness of breath. What do we think she needs to do? She works as a retail associate, dust exposure, history of allergic rhinitis. We avoid triggers. Remember this, okay? So when you look at all the options, they will be right and doesn't mean we don't do them. Like for this, what I'm trying to say is We can first avoid triggers, then look at technique. Then we can do multiple things. So if you pick number four, that doesn't mean we don't do number one, because we will eventually do number one anyways. You always look at inhaler. But the first thing that should come to mind is, oh, there's an allergy. There's IgE. Do you see what I'm saying? Or no? It makes sense in my head. I don't know if it's making sense out loud. Right? So number one is always right. But in this case, we got to do four first because IgE and eosinophils. Clear? So now you know those are the things you look for allergy. Do you have to know lab values by heart? No. Um, there's only like a few things. So potassium, you should know on average potassium is 3.5 to 5. Okay? About 3.5 to 5 is potassium. Okay? On amiodarone again, don't be sorry, that's okay. What if we can't use amiodarone? So if we cannot use amiodarone for the heart failure case in reduced ejection fraction, was there any other medication you think we could use for the patient? We can do another antiarrhythmic. We can do another antiarrhythmic. Yeah, another antiarrhythmic, exactly. But we would stay away from digoxin. Digoxin is like last. Okay. Amiodarone would be the gold standard because of the reduced ejection fraction. However, some studies show that you could use sotalol between 35 to 40. Some studies show, so for exactly. So like push come to shove, if we cannot do amiodarone, we could do sotalol. But I think that would be more beyond your exam. I think on your exam, it would be more like the optic neuritis, the microdeposits, it's more along those lines. And like discontinuation, stuff like that. Next question. Good question, though. Here we go. We'll do this question and then I'll go back to the last one to answer some questions. Now, I saw this concept come up on the last and the one before exam. And this is now I'm finding more common in terms of uh, prevention. It never used to be that way like 5 years ago. I'm seeing this more and more normalized. The answer is three. Vaginal estrogen for prevention. If someone is getting recurrent urinary tract infections, we could do vaginal estrogen in somebody who is postmenopausal. So the key here is postmenopausal, and it's not to treat, it is to reduce the recurrence. Number three. See, in this case, you didn't really need blood work, right? You look at the first line, you look at the last line, and then you read a little bit in the middle. Yeah, it can be as well. Yeah. And I find every patient is different. One patient did cranberry pills for prevention and it worked so good for her. And then my other patient said it did nothing, right? So we have to try different things. But more and more and more now, I'm seeing this come up to prevent recurrence of UTI. Yes. There is lots of emerging evidence for this now. So whenever you look at a case, always look at the first line of the case and then the last line of the case. And then I usually like go look up and down and then I look in the middle. Because when you look up and down, then you kind of have an idea of what you're looking for. You know what I mean? Because you're going to get some short cases, you're going to get some long cases. And because it's like randomly generated, you will see different people get different sets of questions, right? So you just have to do your best in that sense, and you're most welcome. Just looking at your comments and questions. Okay, on to the next one. And then why four? Pseudomonas and hospital. So we're go exactly PIP-TAZ, piperacillin tazobactam, because it is hospital related. Exactly. Exactly. Whenever you think hospital, you got to think broad spectrum right off the bat. Exactly. Exactly. So very straightforward question. Now, everybody gets worried about infectious disease. Um, I made a summary for our students, but because I know you guys have your exam coming up, I'm going to be sharing it with you guys. It's a one-page summary of the main first line treatments for infectious disease. Now, for infectious disease for your exam, you don't have to know second line agents, okay? You have to know pathogen, first line treatment, and then if there's an allergy to first line, like if there's an allergy to amoxicillin, what is the alternative? But you don't have to know second, third line, or anything like that. All you got to do is first line, infecting pathogen, and if the patient has an allergy, what do you do? That's it. That's literally it. Okay, so we're gonna email, I'm gonna show it to you later, but let's you don't I as some students will spend hours on infectious disease. The key for this exam is not the number of hours you study, it's studying smart. Okay, people, I'm not kidding. Every semester, literally, I will see it as a competition. One student will say, like, I did 5,000 questions. Oh, I did 1,000 questions. Or I did 10 hours a day of studying, and I did 12. Like, the quantity doesn't matter. Sometimes, I'm not even kidding. I find people who do more questions are less likely to pass. I see people who do study less. I mean, within reason will study less and pass, and people who study more don't pass. You don't need ample number of questions and ample amount of content. It's being smart, taking what you have and using it and applying it. That's it. That's MCQ. Next question. But yes, hospital acquired Pseudomonas straight to PIP-TAZ. That's it. Next question. I love therapeutics. This is fun. Okay, hope you guys are having fun. I don't want you guys to be stressed. All good vibes, right? Mm-hmm. Exactly. Good. So this one is very straightforward. Diabetic foot infection. Mm-hmm. Outpatient clindamycin. But what other drugs? Diabetic foot infection is one of the few infections that there's so many different antibiotics we can use as first line. What are the other options? Do you guys know? I'm going to write it for you. Amox, yeah. Mm-hmm. Cephalosporins, Clinda, Clox, yeah. Doxy, mm-hmm. Linezolid, sulfamethoxazole trimethoprim. Exactly. So the way I remember diabetic, like mild diabetic outpatient foot infections, this is one of the few infections where you have so many different treatments that you can pick as first line, like fair game. Okay, so this is your list: amoxiclav, Ceph, Clinda, Clox, Doxy, sulfamethoxazole trimethoprim, linezolid. There we go. On to the next one. Straight memorization. The case looks intimidating, but once you kind of get in the groove of it, it makes sense. Next. Outpatient meaning, um, outpatient means like patients are not admitted to the hospital, they're at home. So they're at home and they're being giving medications at home. Now, this concept is so important for you to understand on your exam. Okay? When somebody has shingles, and yes, correct, those drugs were choices for outpatient. Yes. Chickenpox and shingles is the same virus. Chickenpox and
Right.
shingles is the
Infectious
same virus. Okay? You know, when you get a bacterial infection, just make sure you guys are muted, my dear students, because there's some noise coming
You
in here.
can you can
Please, please, there's noise coming in.
you can even pay
Trying to find out who's where it's coming from. Please, please make sure you mute. Let me see here. Okay. So, what I was trying to, let me go backwards. Okay, what I wanted to say was chickenpox, shingles is the same virus, except when you get chickenpox, it's spread by respiratory droplets. Okay, after you get chickenpox, the virus sleeps in your nerve cell. You never get rid of chickenpox, the virus. That virus stays with you for life. It's not like a UTI or acute otitis media or bacterial pneumonia. With bacteria, we're done with it. Like you get rid of it. You take the antibiotic, we're done. Viruses, not all, depends, but these viruses sleep in your nerve cell and reactivate as shingles. Okay? With chickenpox, it is respiratory. You spit on somebody, you talk, it spreads. Shingles, not so much. Shingles is the blisters. So patients will always say to me, Farah, I have a shingles outbreak. You know, I have the blisters and the rash. When is a patient no longer contagious if they have shingles? When are they no longer contagious? Can you guys tell me? Until the last blister has crusted. If a patient has active shingles and they have blisters with fluid in them, do they have to stay home or can they go out and like live their best life? Why do they have to stay home? Why can't they go out? Hmm. So actually, they can go out. And I'll tell you why. The blisters are usually because it's affected by one nerve, right? It's unilateral, one side of the body. As long as the blisters are covered, they can go out because it's not spread by respiratory droplets. As long as it's not like on the patient's hand or it's covered, they can do whatever they want. They can see family, grandkids, whoever they want, as long as it's covered. So that's very important for your exam. Is that clear? Exactly, as long as it's covered. Yeah. And so the answer is definitely C. It's only direct contact with the contagious fluids. Exactly. Yeah, I'm just trying to think if there's anything else I want to add on. No, I think that's it. Okay, next. This concept came up on the exam. Yeah, of course. We will be sharing the recording by email. Of course. Okay, so I'll wait a couple seconds. Okay, first and very important concept. We can never apply DEET and sunscreen together. Never, 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 never. Never, 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 never. Never put sunscreen and DEET together because it can reduce the efficacy. Yes, recording is for everybody who registered, promise. And you can share with non-registered people too. It's for anybody and everybody, just to help you guys with the upcoming exam. Okay, so for your exam, because this has come up, DEET, sunscreen, do not put together. And I will say it like a million times. I'm not kidding. Students tell me they will remember what I say for years. They're like, we'll remember what you say for years because you just repeat it. And I'm like, well, yeah. So, okay, if you put DEET and sunscreen together, it'll inactivate. So it's not going to work. First. Now, second, do you put DEET first or sunscreen first? Like you have to separate it. Like you'll put one on, wait, then you put the second one on. But what do you put first? Sunscreen is first. Sunscreen is first, then the DEET. 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 Sunscreen first, then DEET. You wait, like wait till it absorbs. You wait for the sunscreen to absorb, then you do the DEET, okay? So, but I'm glad you guys are telling me what your answers are because then we work together. So very good. So that's good. Now, back to the question. Answer is number 2. Why is answer number 2? First and foremost, when you're looking at the patient's preferences, look at the paragraph 3, hypersensitivity to skincare products. This patient already has sensitive skin. In people with sensitive skin, icaridin is preferred over DEET. Icaridin is preferred over DEET in people with sensitive skin. Is that clear? Icaridin is less irritating. So that's a trick. And it's effective. Also, when you compare application, icaridin is less frequent. Okay? Less frequent. If when you have a patient is working outdoors, and moving around a lot, that would be ideal. Is PMD ever preferred? If somebody says they want something really natural, some people say it's more natural, but you will never really pick it. I find for your exam, it's more DEET or icaridin, and then they talk about the like what's first, sunscreen or DEET or whatever. Now, does everybody understand why answer was B? Okay, are you on to the next one? Here we go. Okay. Okay, you're right. Answer is 2. Patient has prosthetic valve, right? So we got to look at the prosthetic valve. When somebody has prosthetic valve, what is the benefit of rifampin? What is the benefit? I know it's complicated chapter. What is the benefit of rifampin? What does rifampin help with in somebody with a prosthetic valve? It can penetrate. Exactly, it penetrates the you call prosthetics. Exactly, it penetrates. Exactly. Patient also has MRSA, well, risk factors. So because of that, we're looking at vancomycin. What about CKD? It's a very valid point. So gentamicin is nephrotoxic. You are right. But if we do it with close monitoring in the hospital, low doses and close monitoring, it's okay. So gentamicin is not absolutely contraindicated. We do it with monitoring. Okay. And remember, when you're given a question like this, you may not be given the answer you want, right? So you got to look at all the options and say, okay, well, based on what I'm given, what's the most appropriate? They have a prosthetic valve, we're at risk of MRSA. Based on whatever you're given, you got to pick an answer. So that would be 2. See what I mean? Okay, next. This came up on the exam, like this concept. You have to know this. No matter what you're studying, you have to know this. And why are you guys saying C? Why? Whoever's saying C, tell me why. One thing I always tell students is the answer does, I mean, when you're preparing, the answer doesn't matter. It's how your thought process matters more in preparation. I'll wait for 1 more minute. So we are looking at chloroquine resistance. Because of chloroquine resistance, we like atovaquone proguanil. So that's true. But why not mefloquine? Why don't we pick mefloquine? Cardiac effects, QT prolongation, worsening of arrhythmias. Patient has cardiac concerns. Exactly. So that's why we cannot pick B. We have to pick C. Okay. And because we have chloroquine resistance, we cannot pick A. So we don't use What are the 2 big concerns with mefloquine? There's 2 big concerns. What are the 2 big concerns with mefloquine? Cardiac and psych. Exactly, cardiac and psych. So think now, mefloquine, two big concerns, cardiac and psych. Cardiac and psych. Okay? Why not D? Doxy, it's more like you could use it, but it's like more alternative. You also can get stomach upset, photosensitivity. So if the patient is going to an outdoor area, the doxy can cause more issues, especially with photosensitivity. It's not really our big go-to. It's like you can, but we would do a tobacco and proguanil first. On to the next one. Very good. See, straightforward. Do you guys notice now that you're now that you're like into it, you're getting faster with your answers? This what happens on your exam. I will never forget it. When I went to do my MCQ exam, I am not kidding. I look at the exam and I'm like, I don't know anything. And then I clicked the next page or whatever, next, nothing. Nothing. I'm like, okay. And then I started panicking. I'm like, okay, 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 okay. Then I went to the back, like the you can pick from the side on the computerized exam, the last question of that section. I went to the last question and I worked my way backwards. I found some questions that I knew. When I warmed up, I was able to do more. So that's what's happening to you guys. Do you see how you're warming up? You're getting faster. So on your exam, if you don't know, you think you don't know, look for something you know and then you work backwards. Anyways, answer is C. Syphilis, we go for the penicillin, benzathine penicillin. What is the first exactly, what is the name of the infecting pathogen for syphilis? Treponema pallidum. Like I said, you have to know first line if someone has an allergy and infecting pathogen. Now, what if somebody has an amoxicillin allergy? This is the one condition where we try to do desensitization. But why? Why do we care so much about doing desensitization? Why? For this condition? Why does it matter? Why? Because it works the best, and that's not the only reason. The reason is you don't want it to progress to neurosyphilis. So because the risks of it not being treated properly can lead to neurosyphilis and lifelong issues, we have to do our best to treat it. So because of the neurosyphilis risk, because of that, we want to do our best to treat it properly, which is by penicillin. Does that make sense? So that's the main reason, is because of the risk of neurosyphilis. So when you're most welcome. When syphilis is not treated properly, it can progress to neurosyphilis. It can affect the CNS. Okay, because of that, we don't want to take the chance. We will try to, if somebody has an allergy to penicillin, we'll try to desensitize them. Meaning, like if they have a bad allergy, we'll treat them in the hospital and watch them. If that doesn't work, we tend to go to doxycycline. But 99% of cases, they'll administer it in the hospital. It should be okay. True anaphylactic amoxicillin allergies are rare, and now studies even show if somebody had an amoxicillin allergy as a child, when they're older, they tend to grow out of it anyways. Next question. This came up on the exam. I know I keep saying that, but it's okay. Now, before you answer, look carefully in this question. Look, the patient has oxygen reduced oxygen saturation. The patient is ill. The patient went to the emergency room. Progressive shortness of breath. Now, students will always say, Farah, do I have to know if something is available in IV versus oral? You don't really have to know if it's oral or IV, but what you need to know is when do you pick IV versus oral? So if you look at this question, sulfamethoxazole trimethoprim is the drug of choice. But how do you pick between A and B? How do you pick between oral versus IV? How do you pick? Well, look at the case. Shortness of breath, emergency room, oxygen saturation is not fully there. So this patient, the heart rate is kind of high. The patient's not doing well. Is oral really going to kick in fast enough? No. We have to go to intravenous. So you don't have to memorize if something is oral IV. You got to look at the patient and be like, oh, they really don't look well. Let's do IV. Do you see what I'm saying? If it was a mild case, maybe they went to their family doctor, they're not an emergency, we're not worried about hypoxia and all that stuff, then you do oral. Is that clear? Because this came up. Next one. Okay. Here we go. A little easier now, a little shorter. Straightforward. Okay, exactly. Now, I wanted to ask you guys something so you understand. CD4 count. Do you guys understand the purpose of CD4 count? What is CD4 count? What does it mean, CD4 count? What is the purpose of it? It allows us to understand the patient's immune system. So when you look at the CD4 count, you can say, okay, the patient's immune system is strong, it is weak. Exactly. If someone's CD4 count is low, if it is less than 200, what does that mean? If it's less than 200, you're at risk of infections like this infection, this PCP, pneumocystis jirovecii, PCP. You're at risk of this infection. Exactly. Exactly. So you want the CD4 count to be above 200. When it drops below 200, you're at risk of opportunistic infections. Exactly. Exactly. So you have to know the gold number 200. Okay. Now, every semester, students will ask me, Farah, do I study for all of HIV? Do I study for opportunistic infections? And I'm sure you guys have the same question, so I'm going to tell you what I tell everybody. You will never be able to study everything. You have to pick your battles, right? Opportunistic infections comes up on the exam, like this, PCP. This comes up, which makes sense, right? Pharmacist scope of practice, preventing infections. It makes sense. On your exam, there's also, right, you can get pre-test questions, questions that don't count. So you also have to keep that in mind. So not everything counts. Is it worth it for you to memorize every drug in HIV and spend hours or days learning HIV when HIV itself may be 3, 4 questions? Or is it worth it understanding the likelihood of opportunistic infections coming up and focusing on that? So I always tell students when you're studying HIV, focus on opportunistic infections. If you have time, look at HIV itself, but most people don't have time. Your better shot is to study other topics like minor ailments or other things. Do you get what I'm saying? So literally when I teach in SolRx, I focus on opportunistic infections. I'm like, I think we have this much time and this much material. Let's be smart about it together, right? Opportunistic infections is very important. Anyways, thought I would share my 2 cents with you. Next question. This session, I have about another 20 questions I want to do. So like 30 minutes, 40 minutes. Is that okay? Let's keep going. Okay, I'll stop talking. Let's keep going. Let's keep going. I'm just having a little too much fun. But these tips, I hope they help you. You have to know this for your exam. Certolizumab is the only one
Yeah,
of the
no.
Your students, make sure you're muted, please. Certolizumab is one of the only biologics safe in pregnancy and breastfeeding all throughout. All throughout, you memorize, 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 memorize. Certolizumab, certolizumab, all throughout pregnancy, all throughout breastfeeding, available in Canada. Certolizumab. And when you're memorizing biologics, you should know the TNF alpha inhibitors. Like you have to know which one is a TNF alpha inhibitors. Okay? You have to know that. Okay? On to the next question. We have a lot to get through. Next one. This also came up on the exam. Before I say what the answer is, in one line, what is the difference between Somogy effect and Dawn phenomenon in one line? How can you explain to me if I was a patient and I want to know what is the difference between Somogy effect and Dawn phenomenon in one line? Somogy effect is nocturnal hypoglycemia and then it rebounds to hyper. And then Dawn phenomenon has no hypo. Exactly. Dawn, no hyper. No hypo. Exactly. Why does dawn phenomenon happen? Where there's no hypo, it's just in the morning you get strong high sugars. Why? Hormones. Exactly. Natural body hormones. Very good. And so this patient has late night hypo and then it rebounds to hyper. Exactly. And when that happens, what do we do? What were your guys' answers? Let me see. Go back up there. You want to reduce the bedtime insulin, evening insulin, or you add a snack. Exactly. You either reduce the bedtime insulin or add a snack. This comes up on your exam. This has come up. Make sense? Also, students will tell me, Farah, I have to know insulin or just dosing on the exam. In 9 out of 10 situations, you can actually figure out the dosing. You can figure it out in the sense of when someone is increasing the dose for anything, you want to go slow. You don't want to go fast. You know what I mean? So you always want to go slow with anything. You never rush. If there's an option to choose between snack or reduce insulin, mm, I would reduce the insulin. But the Diabetes Canada says either or is okay. Does that make sense? When I say knowing insulin dose, I mean like, oh, um, uh, if you have to increase basal insulin, is it by 2 to 3 units versus 4 to 5 units, like that? Anytime you are playing with dosing, you always want to go slowly. Does that make sense? If I had to pick between reducing bedtime insulin or giving a snack, I would reduce bedtime insulin. The only reason I would pick bedtime insulin reduction is because, when I think about patients having a snack, how do you know they'll have the same snack every night? You know what I mean? They may have a different snack every night, and then if they don't have the same snack every night, that can affect the levels, you know? Versus if you reduce the bedtime insulin, then at least it's consistent. Makes sense or not really? Like it makes sense in my head. I don't know about out loud. Okay, next. Please make sure you're muted, my dear students. Why do you guys think B? Why B? Why? Mm-hmm. So, salbutamol patients can use up to 8 puffs in a day. I mean, that's not the max. It's like that's the max recommended. But if someone's having a really bad attack, they can use up to 16 puffs. When you go more than 8 puffs in a day, you can get tachycardia and tremors. Exactly. Exactly. On your exam, they test deprescribing. They test how you manage side effects. Like in this case, if we don't read properly, we can say increase metoprolol. They want to make sure on your exam you're not adding on medications without assessing what the patient is currently on. So it's very important before you ever recommend an add-on, you look at what the patient is on. First, see if there's something you can do with that before making any change. Next, you guys are getting the hang of it. Why are you guys saying D? Why? On your exam, you have to know when do we use blood thinners. Heart failure patients do not need blood thinners. Heart failure patients do not need blood thinners. In AFib, patients need blood thinners, right? Because there's the arrhythmia, the blood is not flowing properly, blood is pooling in the heart. But in heart failure, we don't have that problem. In heart failure, no aspirin, no antiplatelets, no anticoagulants. So D. Very good. Next question. Make sure everybody, you guys are all participating, okay? I see everybody online and then I see the number of people participating, just saying. Okay, here we go. Next question. Don't be shy. The thing is, it's like, because we're not all in the same room, everybody's from different parts of the world. And I think the more we participate, the better for everybody, because then everybody benefits together, because we're on the same team, right? What does protein and how does protein affect levodopa? How? High protein can impair levodopa absorption. It comes up on the exam. So is it like 1 hour, 30 minutes, 2 hours absorption and binding? Exactly. 1 hour is the safety number. We say like 30 to 60 minutes before or an hour after food. Exactly. Whenever I talk to Parkinson patients, the first thing I ask them is about their diet. Any changes to their diet? Are they having more protein? First thing I ask, and this always comes up. Someone gets this related question on their exam. The answer is B. Next, here we go. This came up. I know I keep saying that, but that's okay. Oh my gosh, you have to know this. Have to know this. Okay, I'll be quiet. You guys answer it. No, my ginger ale. Every pregnant patient at 27 to 32 weeks must get Tdap. 27 guys, memorized 27 to 32 weeks. Pregnant patients, 27 to 32 weeks. 27 to 32 weeks in each pregnancy must get it. I have two baby boys, well, toddlers now, but remember, first pregnancy and second pregnancy. Every pregnancy, you get this, okay? No matter how many kids, each pregnancy, this literally comes up. Okay, now you're never going to forget it. So A is the answer. And it's not just TD. You also have to get AP. Like you want to get the acellular pertussis, not just tetanus diphtheria. You need the full Tdap. So the full thing. Okay, next question. This also has come up. And then I kind of want to talk about this concept. It is a very confusing concept. The answer is A, but let's talk about it. If somebody is not vaccinated against rabies and they get bitten, they have to do the RIG, the rabies immunoglobulin at the wound site. They've asked on the exam, Is it at the wound site? Yes, it is at the wound site. Okay? And then they also get the injection. You have to know the series. You have to know day 0, 3, 7, and 14. Now, let me ask you this. What if you had a patient who was vaccinated against rabies and they get bitten? What do you do? And if you don't know, you say, Farah, I don't know, because then I'll clarify, because I don't know if you guys know or not. Okay, so if we do, okay, good. Then you tell me. Good. Okay, good. See, now I'm happy you're telling me, then I'll explain. Okay, so let's look at two scenarios. If someone is not vaccinated against rabies, they get bitten. The immunoglobulin has to go around the wound, and then in addition, they get the vaccine. Day 0 means today, then on day 3, day 7, and 14. So that's if someone is not vaccinated and they get bitten. Now, changing gears, someone is vaccinated against rabies and they get bitten. They're not free either. They don't need immunoglobulin. So if someone is vaccinated against rabies and then they get bitten, no immunoglobulin. No immunoglobulin. But they still get the vaccine again. But instead of 4 doses, we do the first 2, day 0 and day 3. So again, if you have been vaccinated, the patient gets bitten, you still get the vaccine, no immunoglobulin, day 0 and day 3. The doctor's office will put the immunoglobulin liquid on the site of injection. The reason, and that's only on day 0, because that'll provide passive immunity on day 0. So on day 0, the doctor will put the immunoglobulin on the site for passive immunity. Just day 0. Okay, I'll say one more time. Not vaccinated. You put the immunoglobulin on the bite site to neutralize, to provide passive immediate immunity. And these patients have to get this on day 0. So today, day 3, 7, and 14. If somebody is vaccinated against rabies already, they've already been vaccinated. You don't need immunoglobulin, even if they have been bitten, no immunoglobulin, but they still get revaccinated. And when they get revaccinated, day 0 and day 3, that's it. Day 0 and day 3, that's it. Is that clear? If not, I will say it again happily. The immunoglobulin is on day 0. So that moment, that second, they get to the emergency room, apply it on the site. Okay? So day 0. Is there an adverse reaction if a patient gets vaccinated, gets immunoglobulin? No. No. When do you do 4 doses? If they have not been vaccinated before. If they have not been vaccinated before. So on day 0, the patient is getting passive immunity from the immunoglobulin and active immunity from the injection at the same time. No, the immunoglobulin is on day 0, just to provide immediate protection. On to the next one. It's my favorite when you guys say you understand, I feel good. Yay! Next one. Okay, where's my mouse? Okay, next. Here we go. You're most welcome, dear students. Next one. This one's confusing, and this came up recently now with the Prevnar 20 shot. And I have a little summary for you after. if they were vaccinated against rabies, they still have to get the vaccine again day 0 and day 3. I find even doctors, physicians get this confused when to do Prevnar 20. I see a lot of confusion.
Yeah,
Okay, so before we answer this question, I'm going to show you the next slide, and I'm going to explain it. Okay, this is what I provided to my students in class. Let's look at the bottom together. I want you to read it with me, okay? Let's read this together. There are 2 pneumonia shots that have been around until now. You had Prevnar 13 and the Pneumovax 23. So I just call it the 13 strain and the 23 strain. Those are the 2 pneumococcal vaccines that have been around for years. Now there's the new one, the 20. So when do we use it? What happens? If somebody has already had both 13 and 23, they don't actually need the new Prevnar 20. If they've already had 13 and 23, they don't need the 20. Okay. If they've only had 13, or if they've already had 23, but they didn't have both, then they should get 20. So that's bullet 2. If switching from 13 to 20 or 23 to 20, we can do that, but it has to be 1 year later. So they have to wait a year. Do you understand before I move to bullet number 3? Do we understand bullet 1 and 2 or no? So until now, we've had the pneumonia 13 and pneumonia 23 until now. If somebody has had that full series, because each patient should get 13 and 23, if they've had that full series, they're done. They don't need 20. They're done. But what if you have a patient who only had 13 or only had 23? Should they get 13 or 23 to finish that series? No. If they've only had 13 or only had 23, the next vaccine should be Prevnar 20. That's what bullet number 2 means. In the past, it was like, okay, you get 13, then you get 23. If you got 23 first, then you get 13. Now it's like, no, if you got 13, we're going to finish it with 20. If you got 23, we're going to finish it with 20. That's what number 2 means. And then on top of that, you have to know the time frame, which is 1 year. You have to know the time frame. So if they got 13, they got to wait a year before they get 20. If they had 23, they have to wait a year before they get 20. 23, then 20. Unless they have a very weak immune system. Then bullet number 3, if somebody's never had the pneumonia 13 or 23, if they've never had it, forget about it. They just go straight to Prevnar 20, which is a one-time dose. If they've never had 13 or 23, forget it. We go straight to 20. Now, let me go one step further. In bullet 1, I said if they've had 13 and 23, they don't need 20. Studies show if the patient is very immunocompromised, very weak, had a history of cancer, they can get 20 even though they've had 13 and 23 after 5 years. I know this is so confusing. Did that make any sense to anybody or not really? We can do it again. Over 65 years of age. Okay, I'm going to just say it one more time. The pneumonia vaccines to date were always 13 and 23. And it was like you get 13, then 23, or if you got 23 first, then you get 13. Now we got the 20. So where does it fit in? Let's say you got a patient who had 13. They need to finish the series, so they'll finish it with getting 20. If they had 23, they'll finish the series with 20. But the spacing will be 1 year, which is important for your exam, 1 year. What if someone never had, like they just turned 65, they've never had 13, they've never had 23? Fine. Don't get those. They're old. They're done. We only get 20. Single, that's it. That's the new standard. Ideally over 65 years of age, under 65 if they're immunocompromised. Now, I have patients who are like, hey, I have had 13 and 23, but I have an autoimmune disease. I had a history of cancer. Should I get the 20? So that's where the gray area comes in. The studies say if you want to get the 20, even though you already had 13 and 23, wait 5 years, then you can get the 20 if you have a weak immunity and you discuss it with your doctor. So it's not routine, but if you want it, you can get it. Does that make sense? After 5 years. That was hard to explain. I'm like, okay. It's so confusing. And if you try to read it online, it's gonna like pull your hair out. So hopefully that summarizes it for you. Okay, now let's go back to the question. Okay, you're welcome. Okay, let's go back to the question. Here we go. Here, now let's try the question. You're most welcome, my dear students. Let's try this. I missed you guys too. Come join us at SolRx. We have so much fun. But anyways, I'm so glad. Aw, I miss you guys too. It's gonna be a good time. Now with what we said, what do you think about this? How would you answer? Woohoo! Yes. Answer is B, exactly. Exactly. Perfect. You're most welcome. Perfect. So weakened immunity after 5 years, we'll figure it out. Whew. Okay, that was stressful. Okay, next one. So we got this down. Next question. I know this is not multiple choice, this question, but that's okay. I wanted to kind of see where your guys' head is at for this. Like, how do you start basal? You should have a general idea of how to start basal. I'm going to write it for you. Basic starting dose is usually 10 units at bedtime. We also look at weight, but just in general, we start with 10 units and increase by 1 unit daily until target. However, in lean patients, so if their weight is less than 50 kilos, we start exactly 0.1 to 0.2 units per kg. Memorize this, guys. This is only for basal. This is only for basal. You have to know this. So when you're done writing it down, let me know. Make sense? Memorize, memorize, memorize. Perfect. Okay, good. Next question. This is for basal insulin. This is general rule of thumb for the basal insulin, like glargine, basal insulin. Okay. Bolus is separate. Let's keep going and then we can talk about bolus. So this answers the question we just talked about, basically. When you have a patient whose sugars are, take a look at this question, then we can take it up. If somebody is 90 pounds, what is 90 pounds in kilos? 90 pounds is how many kilos? Let's say roughly 40, 41. 41 kg is less than 50 kg. So when we are dosing basal, we will do 0.1 to 0.2 units per kg. If you had to pick on your exam, let's say you had, let's say option A was 0.1 units per kg and option B was 0.2 units per kg. Which one would you pick? Would you pick A or would you pick B? Why? Why? You're right, but why? Lowest, always go slow and slow, always, because they test safety on your exam. Because you can always increase. Remember in diabetes, hypo, hypoglycemia is way more harmful than hyper. Hypoglycemia is way more harmful than hyperglycemia. So keep that in mind. Okay? Hypo is way more harmful. Always go low. So I'm telling you, they can literally do this to you. They can say A.1, B.2, and then you're like, they're both right. But they're trying to test your ability to look at safety. That's basically what they're testing. Okay, good. On to the next one. This came up on the exam. And then after this one, we'll do a calculation for the bolus insulin. So this came up on the exam. If somebody starts basal insulin, you don't have to stop secretagogues. So you don't have to stop glycoside and things like that. If somebody starts bolus insulin, then you have to stop. Does that make sense? With basal insulin, you don't have to stop this insulin secretagogues. Only with bolus insulin, you have to stop. Clear? Answer is number one, because glycoside is the secretagogue. Only with bolus, not with basal. This has come up on the exam, and people will get it confused. Basal, it's fine. It's bolus that we're concerned about. Okay, on to the next one. We're going to do some calculation. So look at the patient's weight, because I'm going to pull up a blank screen here. Look at their weight, 168 pounds. She was just diagnosed with type 1 diabetes. So if they have type 1 diabetes, they have no insulin in their body. They need basal and bolus insulin, right? Basal and bolus insulin. So she's 168 pounds. So let me pull up a blank slide so we can write it out together. Let me get my calculator. So if somebody's 168 pounds is how much in? All right, let's round. It's 76 kilos. When you are dosing insulin for type 1 diabetes, you first want to look at total daily insulin. So this is called TDI. How much insulin do they need in 24 hours? So they need, and I'll tell you here, let me just extend this. They need 0.5 units per kg in somebody who has type 1 diabetes who's getting basal and bolus insulin. So that's about 38 units. Does that make sense? Does everybody know how I got here? So when somebody has type 1 diabetes, we're looking at basal and bolus insulin. But how much do they need in 24 hours? That's your TDI, your total daily insulin. And you're most welcome. This is total daily insulin. The total daily insulin is 0.5 units per kg. So 0.5 times 76 gives you 38 units. That's their total daily insulin, how much they need in 24 hours. Okay? Now we got to calculate basal. This is type 1. Yes, because in type 1, we need basal and bolus at the same time. Okay, type 1. So now, how do you calculate basal? Basal is 40% of total daily insulin. 0.5 units per kg is standard treatment. You have to memorize that, strict memorization. And then bolus is 60% of total daily. So what is 40%? 15.3, 15. Let's do 15. And then what is bolus? For now, we'll round up just for today. On your exam, do decimal points, but right now we'll just round. Now, so for basal, the patient will do 15 units QHS of basal insulin. Bolus, this is meal related, right? So let's pretend they have 3 meals per day. If patient has 3 meals per day, It's about 7.6. So let's round down because insulin can be harmful each meal. But because PBC is sneaky, what if the question says they have 5 meals? Be careful. Never assume 3 meals. Check the question because then you'll divide it differently. Does that make sense? They can say 5 meals. You don't know. I don't trust PBC. I don't trust anybody. You know what I mean? Right? So look on the exam. Is it 5 meal? Is it 3 meals? Are they sick and they're only eating one? Like, I don't know. Just be careful. Now, do you guys understand this? Okay, I'll wait like 10 seconds. I know PBC is. For your exam, this is how you have to treat it. This is the extent you need. Okay, next question. Now back to the slide. Okay, back to the multiple choice questions. 60 and 40 is memorized. Strict memorization, yes. If they eat once a day, ideally we still wouldn't give them 60%. Like we would still give them less because that would be too much. Okay, now for this question with acne, in people with acne, you have to look at if they have sensitive skin or not. This patient has sensitive skin. Because they have sensitive skin, you want to pick the retinoid that's the least irritating. The retinoid that is least irritating is adapalene. So on your exam, adapalene is the least irritating. Okay? Tazarotene, tazarotene is the most potent. Tazarotene is the most potent and the most irritating. Adapalene is the least irritating. So adapalene is the least irritating. Tazarotene is the strongest and the most irritating. So answer is C. Very good. Next question. Changing things up a little. So why did you pick C? Why do you guys pick C? Because it's highly hematogenic chemotherapy. Exactly. So you got to do the full treatment. Exactly. You got to do the NK1, the serotonin receptor antagonist, dexamethasone, olanzapine. Perfect. Standard of treatment for highly hematogenic. Perfect. Perfect. Next question. Perfect. Next. So this patient had steroid-induced hyperglycemia. So in somebody with the moderate hematogenic potential treatment, you would have longer dexamethasone treatment, right? Up until day 4. But because he has issues with the steroid, we have to shorten it. You should not take out dexamethasone completely. If you take out dexamethasone completely, it can actually cause very bad nausea. So the best thing to do in this case is B, give them dexamethasone only on day one. So you don't take it out completely. So in a patient like this, you don't want to take it out completely. You want to minimize it. So instead of taking it out completely, we'll do B. Okay, so do not take it out completely because it can cause significant issues and bad nausea. That's why the answer is B. Okay, straight memorization. Next, we're almost there. I know it's a lot. It's almost been 2 hours. We're almost there. Almost there. And if we don't know, that's okay too. So for these patients, you're right. The answer is D. If somebody has breakthrough nausea, vomiting, and they are taking something that's highly emetogenic, you want to add a dopamine antagonist. So if somebody, and I'll say it again, if somebody has a chemo that is highly emetogenic, and they're getting breakthrough episodes, we want to add on a dopamine antagonist, which would be D, either metoclopramide or prochlorperazine. Metoclopramide or prochlor. Breakthrough means it's like even though they're getting treatment, they randomly during the day will still get nausea, like at 2 p.m., 5 p.m., 7 p.m. They'll randomly get episodes of nausea. Okay. Makes sense? So again, highly emetogenic. You don't need to know every drug, but there's a few drugs. Sometimes they will tell you highly emetogenic, sometimes they won't. But you should know cisplatin is highly emetogenic. That one you should know. So in highly emetogenic chemo, if they're getting breakthrough symptoms, we add dopamine antagonist. You could do olanzapine, but it's not standard of practice in this scenario. This would be standard of practice. Okay. Next. Almost there. So in somebody very good with low hematogenic potential, exactly. We don't need prophylaxis, so it's not routine. Even using the serotonin receptor antagonist on day one, it's like optional. So low hematogenic potential, capecitabine, for example, fludarabine, you do not need it. So A is the answer. Correct. Correct. Strict memorization. On to the next one. Almost there, almost there, almost there, almost there. Here we go. We have 1, 2, 3, 4, 5, 7 more to go. I'll wait a couple more seconds. You guys are correct. Answer is B. Very good. When someone has hypercalcemia, hyperphosphatemia, we need to get off of the calcium-based binders. And then you switch to sevelamer carbonate. Strict memorization. Sevelamer carbonate is non-calcium, so they call it calcium sparing agent. Very good. Very good. And we keep up the vitamin D analog because you don't want to throw off the parathyroid hormone. So that stays. When calcium levels are too high, we have to switch to a non-calcium binder. So sevelamer would be one of those options. Sevelamer carbonate is non-calcium because the patient has hypercalcemia, so we have to stop. But the patient still has high phosphate. We need to get rid of the phosphate. So that's why we would go towards sevelamer. Okay. Next. Almost there, guys. Not clear? So calcium and phosphate work together. When somebody wants to get rid of phosphate, they can take calcium and calcium will bind phosphate to excrete phosphate. When someone has kidney disease, they're unable to excrete phosphate efficiently and they get high phosphate in the blood. So we'll first try giving them calcium because if you give them calcium, calcium will bind phosphate and then it'll come out. But the problem with that is sometimes it can cause high calcium in the blood. And then if that happens and they get high calcium in the blood, then how are we going to get rid of the phosphate? Then you use a non-calcium binder instead. So we stop the calcium and we'll use something like sevelamer or lanthanum to get the phosphate out without increasing the calcium level. Now, to go to this question, next question, please make sure I muted my dear students. Here we go. So, you're most welcome. So this is an interesting one. A patient had a medical abortion, but they have a little bit of light bleeding and cramping, but there's no fever. So what do? You are right that C is the answer. The reason why I put this question here is a lot of patients will worry. They'll say, oh, medical abortion and still breeding, go to emerge. But no, there's no need to go to emerge. In this case, because it's mild, no fever, no chills, no systemic symptoms, they can take another dose safely at home and then see their doctor. So the key is we don't have to jump for them to go to emerge just because they had a medical abortion. When you look at the patient as a whole and the symptoms are very mild, it's okay. We do one dose and arrange follow-up, and then they can get checked out. They don't need another full course because it's just very light bleeding. We don't need another full course. We wouldn't need it. There's just a little bit, maybe some tissue left. You're most welcome. On to the next one. We wouldn't worry about surgery. That would be maybe if someone had like bad fever and they're very, very sick, they would go to emergency. But that's beyond our exam. The key is for you to be able to identify, do they have to go to emerge or can they be treated as outpatient? So this is very important on your exam. Very good. Very good. You have to always greet patients based on their affirmed name and pronouns. Okay. Yeah, we need to have their legal name or for their health card or whatever it may be, but the name they want to go by is what's on the label. So what they want is what's on the label, but we can keep on file the legal name. Exactly. Exactly. And staff must always be educated. Very good. Next question. The answer was being the last one. In this question, the answer is also B, because we want to ensure all intake forms are more broad. You have gender identity pronouns, sex assigned at birth is also important to keep separate as well. We want to make sure the patient is addressed with the name they want and the pronouns that they want. Male and females as the main source of the intake forms is not appropriate. Very inclusive, exactly. So answer is B. Next question. We're almost there. For a patient's name that hasn't been changed legally, we put the name that they want to be addressed as. The name that they want to be addressed as. And in this question, very good answer is C. The key is staff education and training and asking the patient for feedback on how the team can improve. Absolutely. So how can the team improve? Very good. Perfect. On to the next one. Almost there. We're almost done, guys. I know it's been a long evening. Two more questions and then we're done. This one is super straightforward. Patient has allergies. So in that case, we would do allopatadine. Super straightforward. When somebody has discharge that's watery, itchy eyes, no crusting, no discoloration, no other symptoms, this works. If it was unilateral, yeah, we would refer because typically that could be viral. Exactly. Exactly. And then last but not least, one more to go. So in this case, we would do an urgent assessment because the patient also has cancer. They're on immunotherapy. It's not something we would treat on our own. So in this case, we have to refer. This is something they can ask you on your exam. Is it something a minor ailment that we can treat? But when somebody is significantly immunocompromised, they need to be fully assessed. And we did it. I'm just going to take the question online. I didn't do energy drink before my exam. I did a very small coffee, not too much coffee because then you get jittery and then you have to urinate. So just and eat something light, small coffee. Don't eat too much. You should be okay. Now, before I show you the summary, we're actually going to email out the summary, but I'll show it to you. But before that, I kind of want to just say a few words about your exam. Then we'll go to the summary. Okay? When you are preparing for the exam, I want you to remember a couple of things that you're not just preparing for the exam, you're preparing for your future. So you have to be confident. You won't know everything. You have to take every day as you're going to get better, but you don't know everything. Make sure you sleep and make sure you rest and make sure you're not drained. If you are drained emotionally and mentally, you will not be able to perform on your exam. Okay? So that's one thing. And take the anxiety you have and try to use that in a positive way towards readiness. So when you're anxious, say, you know what, my body is preparing for the exam, and this is how my body is releasing that. So try to reframe that anxiety as showing yourself that your body is preparing. Some people like music in the morning of their exam. They have their anthems, their favorite songs. Make something positive the morning of your exam and make sure you stretch, you walk, take deep breaths. Don't follow social media and don't follow all these groups. You're trying this question, that question. Everybody is saying, I did this. Follow your heart and follow yourself. So I want to say that, like, on behalf of myself, SolRx, we're here for you for this exam, for your career. And we hope to see you in the upcoming semesters, but I just want to really say that. But we're not done yet. I just wanted to say that first, and thank you for the kind words. But now I want to show you. Look at this. So this is what we provided our students in class. So we have summaries like this for our students. This is just a sample. We're going to be emailing this out to you guys tomorrow, just as an extra sample. I also will include an anxiety and psychosis drug summary and a couple of management summaries, just something small to help you. But this is what you need for infectious disease. You need the infecting pathogen and the treatment. That's what you need. It doesn't have to get complicated. So that's why I made this. I said, you know what? This is what you need. Don't get caught up in the antibiograms and the pathogen, first line treatment, and allergy. That's it. So we're going to provide this to you tomorrow. So that's what I wanted to show you. And other than that, topics to pay attention to, you have to study everything, a little bit of everything. You won't be able to know everything, but if you've taken a proper course to guide you, you will know what to focus on, right? Like I've told you, do this, know this, know this. Okay. So you will hear from us by email tomorrow. If you have questions, you can look up SolRx. Our phone numbers are there. You know where to reach out to us on WhatsApp. You can call us if you have questions. I just want to say on behalf of all of us, we're here for you, and I hope to hear from you. Our courses are going to be starting soon for the next semester, but regardless, we're here for you. Please stay positive. And for those who didn't get the email, just send us a message or post on the WhatsApp groups, and this will be recorded and resent. Please keep in touch on the groups. I just want to say stay positive and I wish you all the best. And you'll get an email from us tomorrow. Stay positive and stay strong. And you guys got this. Okay, my lovely dear students? I hope you guys have a wonderful day and we'll see you soon. Thank you for the kind words. Have a good night and thank you so much for joining. Bye, everybody. Bye.